Welcome back to Finding Common Ground with Heather and Steve. Today we're speaking with Brad Hansen, who's part of the Healthy Minds, Healthy Kids campaign. He's going to go over some of the resources that they offer, as well as some of the things we can talk to our legislators about so that we can kind of level the playing field a little bit better and make sure the funding that OMH, the Office of Mental Health, is receiving really is substantial enough to meet the need that we're seeing in our community now. So glad to have you, Brad. Thanks for coming.
Thanks for having me.
Hi, Brad. I met you through Healthy Minds, Healthy Kids campaign. I had signed up for one of your programs to become to work with one of your youth councils. And along the way, I found a lot of collaboration with some of the things that I see daily with mental health through foster care, through juvenile PINS programs, through respite care, and regular kids in the school systems all having pretty serious mental issues going on that aren't being addressed. And I thought that would be great to have your program because it's addressing a lot of those topics in a really great way. And I was wondering if maybe you could tell us a little bit about yourself.
Yeah, happy to. Thanks for having me on. So I'm the Director of Public Policy at Families Together in New York State. We're a statewide network of families and young people with lived experience navigating systems and really any system. We're talking about like mental health, education, addiction, child welfare, juvenile justice, developmental disabilities, and so on. And even like child poverty, if you want to think about that as a system too. We also train and credential family peer advocates and youth peer advocates across the state who help families and other young people navigate systems. They've been there. I'm sure you're all familiar with that, the idea of peer support. Well, parents need peer support too, and as do young people. So we play a role in making sure that workforce exists and has what they need and get funded. And that's a big part of what like our organization contributes to the world. And we're also proud members of the campaign for Healthy Minds, Healthy Kids, which is all about trying to expand access to youth mental health services in a timely way in their community when they need it.
I was looking at some of your infographics. They have a bunch of flyers. And so Steve had sent me some before the show started. And I know some of the stats for adults. When I was in behavioral health and long-term care, we used to always tell people, I'm so sorry there's a long wait list, but there's only one psychiatrist for every 11,000 adults who need it. Well, your statistic was terrifying to me because it was way worse. It was like, I think 23, I can't even remember, but it was like hundreds of thousands of children are waiting for like a few providers. And when you just think about the magnitude of that and what can we do before that psychiatrist is available? I keep thinking to myself, in a time where a lot of professions are short-staffed, and we just don't have the expertise, who are the people in between that, professional who has all those years of experience in the person? Because we can't wait a year to get treatment when we're in a crisis. If we address something when it's tiny, it doesn't have to get big. So do you have any thoughts on just that piece of it, that urgency is so there, but I feel like we're kind of stuck in systems that aren't flexible sometimes?
Yeah. The system itself is really complicated, right? And you're speaking to like some of those complications. And it's so hard to like sort of walk back, like, okay, in your example, like, are you a parent who's on Medicaid? Or are you a parent maybe who's accessing your CHIP, mm-hmm. the Child Health Plus program, the sort of the in-between? Or are you on commercial insurance, right? Like our system opens with that. Not so much as out of concern or like, oh, we care about you, we're going to get you help right away. It's like, well, okay, what's your insurance? And that kind of dictates where you get help from. And so I wish there was like a far easier answer to that question. I think, we want, start with just like the vision, we want, no matter what system or insurance that you're a part of, you should be able to get help. You should be able to, a young person should be able to talk to somebody about what's happening to them, what's happened to them, and that can be just peer-to-peer conversations. Like that can be amongst your student, to fellow students or friends. That can be maybe to a school counselor. Like that's good. Or I mean, really, it should start with like, families should feel comfortable having conversations about their well-being with one another. And I think when things get worse, it's partly because that maybe that climate isn't there, and maybe the relationships aren't there, and now things have gone progressively worse. Some of the psychologists that we work with in the campaign relate it to like strep throat, whereas strep throat is very simple and treatable when it's been detected. And it gets progressively harder to treat and more complicated and more deadly and fatal as you wait. And I think that's kind of that's one way to understand like what's happening in the children's mental health system now, is that people wait and they're not able to, the system's so complicated that you kind of maybe don't want to, even if you find yourself ready to. So like when people are ready to engage in mental health services, they're now thrusted into the system where they have to figure out how it works. And there isn't really good instructions on how to do that. And so like there's people like, that have been through it before, like Steve, right? And probably you as well. And also like the family peer advocates that we train and credential. These are all people who have had this experience. And then they have to, they have some sense, right, of like, here's where to start, because that's even like the biggest question sometimes, once you get past like, I need help, my child needs help. And now I've got to, well, my child is ready to accept help and is interested in engaging in services. All right, now where do we go? And this is where like, we're talking about waitlists and things like that. It just gets so complicated, right? You're now in this place where, okay, all these things are in place, you're ready, and then now please wait. And that is generally like the experience of families and young people in New York State. And if they're on Medicaid, there's programs like CFTSS, it's called Child and Family Treatment Support Services. And that can get you connected to licensed practitioners. It can get you to psychosocial rehabs, skill builders, peer support. And those are considered supposedly like touch, right? But there's wait lists for those things. And so, if you're a family, I wish there was a simpler answer, but the system isn't really built to meet those needs in a sort of low stakes, and you're ready, come on in sort of way. And that's part of what we want to change.
And I think that you've made such a good point about when you're finally ready, because as a school psychologist at the beginning of my career, I was in homes. So usually a doctor had said to a parent, something seems a little off. You should have people come in and take a look, in a really low-key kind of way. They didn't really prep them for what was happening. Then I walk in the door and I think, ooh, this looks like autism, or this is a significant learning difficulty here that we're looking at. And you can tell the parents, it was already hard to call me. It was hard to tell the doctor that they felt like something was wrong. Then it was really hard to make the appointment with me. Now I'm not a doctor, so now I'm not going to tell them everything a doctor would tell them, but I always felt like it was my responsibility to prep them. But when I started my career 25 years ago, if I made a judgment call in that room and I was like, this family's in crisis and they really need support right away, I could call somebody and have somebody at the house at the same time as me. They would meet me in the home. Now I can call mobile crisis and it could take hours for them to show up, and I feel like that's, it's really sad, because normally when we move forward and years and decades go by, a system improves. Like we say, oh, we used to do that and that didn't work and now we're doing this. And instead we're in a situation where like, man, 5 years ago, we had a lot more resources or things that could immediately support a family. And I don't know if this is too big of a question, but do you have a sense of why? Is it a funding thing, an organizational thing, like more complex people thing?
Yeah. I think it's certainly systemic, and you can certainly draw like a through line to funding generally, like in the suite of services that I was just talking about. Um, there was this, I guess to back up, there's this push to transition to Medicaid managed care. There was this push to really, like in the time of the Affordable Care Act, trying the state to take the opportunity to reconfigure their system, and turns like the groups like the Medicaid redesign team, you might recall, like these things were meant to make the system easier to be able and equipped to treat more young people. There was these estimates around like 200,000 young people would be able to access, more on the preventative upstream side of mental health services. Things like waivers that used to kind of folded in together and available to everybody. That was the sort of goal with that. But there were some major things overlooked in their assumptions. And I almost feel like because it was such a big transition and overhaul of the system that like the details kind of fell to the wayside a little bit. And I think the children's mental health system is one of the bigger victims of that, right? Because there were things overlooked like child and family treatment support services. These are supposed to be home and community based. So that idea that you're talking about of like, all right, I'm the school counselor, I'm going to call somebody and they can meet me there. That the system, they didn't really build the rates to accomplish that thing. They made it very difficult. There's a lot of administrative barriers, kind of getting things like medical necessity from your doctor before you can engage in those services. These are all like sort of like slowdowns that happen. Presuming that happens, though, the rates for these services, they made all these assumptions that like you'd somehow just be able to serve so many children, almost like a scales of economy kind of thinking of like you're just like we're producing widgets, right? That we're just like the scale is going to be massive, so that we can actually make the rate really low, because you'll be seeing so many children, you'll be seeing so many families and supporting them. It's going to be wild. You'll be flushed with cash programs. And that's really not how it played out. Their volume assumptions were really like half that, because you recognize people aren't just coming to your program like clinics, right?
You're not putting a Band-Aid on and sending them back, or like setting an arm and putting a cast on it. Okay, you're going to come back, we'll take the cast off, you'll be fine. Mental health is so different.
Yeah, but what I mean is literally like the logistics of like clinics is people come to you, the clinician sits there in their desk and people come all day. And maybe in theory you could see 28 people a week. But for home and community-based services, you're going out to them, right? You're going out to their home. You're going out to their community. Maybe you're meeting them at school. So there's travel considerations and things like that. And like, we're talking to some of these programs recently, and they're saying like, I mean, at best, we might meet 2 to 3 people that day, right? And we're not getting paid for any of the staff time that goes into getting out there. You're talking about rural mental health programs too, where it's like an hour and a half of driving just to get out to them. But we're going to give you this flat rate that assumes that you'll be seeing maybe 5 or 7 people that day. And what this has meant for home and community-based programming, they just can't afford to make ends meet. And they're basically begging on skeleton crews of people like just trying to find alternative funding to support it, or just straight up not participating in the program altogether. There's a lot of programs that are just stepping away, de-designating. So this was on paper, this was really promising. But when you came down to practice, you can't get high quality in the home services on the cheap, and that was the major assumption that the state made. And so that original I mentioned 200,000 people that were supposed to be getting services is less than 10% of it that actually are getting those services. And you talk to any of those program providers, like, yeah, we can't. No, like you're talking like in peer support, for instance, people working just part-time, per diem, not getting benefits. And that's not an attractive proposition. And you like go up the line, like, would you work for that much? You know, like really, like in clinicians have 8 years of education, getting paid some of the lowest possible, among all of the, like the lowest on the totem pole.
And you're going into a house in crisis or a neighborhood in crisis or communities that are strained, and some people are very happy that you're there and other people are not. So it is not like you walk in and they're like, thank goodness you're here. Some families do and some don't. You know, so there's a stress level that's hard to describe unless you've done it. I'm a firm believer, and I know Steve is too, that the providers need to be in the home. They need to, it gives you so much information when you walk into somebody's house. Just so many things become abundantly clear, just the interactions between them, maybe the way the house is set up. Oh my gosh, I didn't realize that, you know, grandma, grandpa, and your aunt, uncle, and 10 kids are also living here. Wow, that's a lot of people in this apartment. You know, and then things start to make sense when you can see the whole picture. And that's why in my mind, I know we need psychologists and psychiatrists because they have those years of schooling. But I love the idea of peers, because there are people who don't have all the, you know, the job titles and the degrees and paper on the wall, but they have the lived experience. And if nothing else, they can be somebody the family can connect with and feel like they're not alone. Because I think that sense of loneliness and being isolated only makes the mental health piece worse. And I know from so many cases that if a child is in crisis, the family is in crisis. It doesn't matter if one of the children has profound autism and you think they don't even know, you know, oh, they don't realize that, you know, Joey's having such a hard time. They do. They just can't communicate it. And they might have more behaviors and sleep issues and all these things happen. And, you know, maybe dad's working longer to pay for this or that, and he's not home. And all these things come into play. And I think the American families right now have a different kind of strain, you know, economically speaking and socially speaking. Coming off a pandemic, it's not like we have a lot of reference points for something like this, but we have not recovered. When people are like, oh, we've resumed our normal activity, you know, I think, man, I don't know. When I go to a restaurant and they're closing at 7, I think a restaurant closing at 7, that doesn't seem normal. That's a restaurant. Then you think about hospitals and urgent cares and clinics, and we're just not where we were 5 years ago.
Yeah.
Brad, I wanted to mention the numbers that we go by with at Healthy Minds, Healthy Kids. I don't even think that I think it's just the tip of the iceberg, because a lot of kids that come through my home aren't even diagnosed yet. We see mental health issues because of the trauma, and to get on a 1 or 2 year waiting list to even find out if they got a mental health diagnosis, which they probably do, they're not even figured in any of these totals that are on the state, because they're not even. It's not even on anybody's radar anywhere.
They're not on the books yet.
Yeah, we see it, and so those numbers are probably low. And, you know, going back to what Heather mentioned about the therapeutical end for mental health is, and I've had this discussion with you before, Brad, when kids come through foster care, the last thing you want to do is go down to the opposite where they were torn away from their parent. And that's where they have the therapy. So, you know, what I do is I go into court and I ask to do it in my home. And we actually have some of our kids getting some of the community services and home-based services outside of foster care. If we adopt them, we can use those services. But when they're in foster care, they can't really use the services because they're under another regulation. They're not under OMH. They're under OCFS. And it's a mess. And some of these kids have to go down to the office every week, and the mental health never gets fixed because we don't have a diagnosis for it, and so they don't address it with the half-hour sessions or so that they have with them. So I applaud what you guys are trying to do. It can be, I'm sure it's daunting, but it is so necessary.
Yeah, I mean, we're talking a lot about wait lists, right? Like that time it takes from referral to a program to getting an intake to then getting your first service appointment. And we just did a survey of some providers, and it's preliminary what I'm about to say, but it's like 20% of clinics of the clinics that responded were saying that they have wait lists of over 50 days, right? And that probably deserves like a moment, like, oh my God, like what does that mean for a child who needs help, is going through something, and children experience life and time so differently than adults do. And so every one of those days is a day of feeling that like you didn't matter or no one cares about you. And we hear that from the young people we talk to. We actually and you'll remember this, Steve, we did a community speak out on October 8th. And we had a parent and a young person who together, this is the mom and the daughter talking about their experience. And this had this sort of like parallel thing going on. Like for the daughter who is sitting on a wait list, who's like 15, who doesn't really understand the system, she's asked for help, and her mom is activated, trying to get her what she needs. She's even a trained family peer advocate, right? So this is someone who kind of knows the system and still found themselves powerless to get them the care they needed. That they were while they were sitting on wait lists, that strain. What is that child's experience of this like? And for the mom, it's like there's nothing I can do for her. And how much of a gut-wrenching experience that must be, of being on phone calls, calling every single program you possibly can, begging for help. And the daughter, her experience, she described as like, I felt like no one, like you didn't care about me. I feel like I asked for help and you didn't take me seriously. That you just left me alone. And that, and so the dynamic between them suffered. And she felt abandoned. Right. And it was so, in so many ways, like you can tell how far they've come from that. They're sitting on this call, they're sitting on this statewide call, people with a big audience, like talking about this very vulnerable thing. And the daughter now in college, great, there's this, in a way, a success story, right? She's in college, talking about this in hindsight and just expressing empathy for mom. Mm-hmm. And I think that in itself, I was really moved by that. Because this is so intergenerational. Like I want to go back to something, Heather, you mentioned, is like the stress of parenting post-COVID, especially. But like, I think just generally that is true. But like the Surgeon General just put out a report that's worth looking at. I don't remember the exact name of it, but it sort of looks at parental stress, looking at things like economics, right? Just like the dinner table stress that families are going through. But also how that translates into stress, like the stress of managing their children's behaviors who are more and more young people presenting anxiety and depression and suicidal ideation. Now parents are just stressed out and to the brink, and they need support too. Mm-hmm. Right? Yeah. And like if a parent isn't doing well, odds are the child's aren't doing well either. And that they're sort of, we need to kind of approach this in a whole way.
Agreed. Yeah.
Yeah.
I think coping skills and strategies are really based on what you've seen other people do. If your mom takes a deep breath every time she gets upset, you'll see the little kids doing the same thing. And they're like doing the same expression. Everything is the same. You think, you're teaching them to take a big breath. That's awesome. Other parents throw something at the wall, right? Or they scream and swear, or they break something. And then we're shocked when the kids do the same thing. And in the field of autism, very early on, I watched this mom and she would grab her kid's chin and she'd turn his face and say, "Look at me." And she was just frustrated. Like he was so detached. She wanted to reach him. Her intentions were actually pure. But then 6 months later, we get him in a preschool class and he's grabbing the teacher's face and screaming, "Look at me." Totally inappropriate. And the mom just shrunk down. And I thought, yeah, we have those aha moments as parents where like, man, I did not handle that right, or I didn't use the right expression or the right strategy. And now my kid is doing the same thing as me. And there's a guilt factor that sometimes blocks getting help because they almost are embarrassed and don't want people to know where the kid picked up that habit, or that you weren't able to provide them with something that they felt like they needed. And that's too bad, because then it just gets worse. What would you say would be the hardest case for you, like for mental health wise? Like what is the system lacking the most? Like what, because, like different populations, different crises, is there a certain segment that you would say has a higher prevalence or inability for us to serve them? I know there's a lot of ways to go with this. Sorry.
Yeah, that's a big question. They're all, there's a lot of complicated things that go into answering that question. And I should also say, Heather, to be clear, even if I've been sounding like this, I'm not a mental health professional. Mm-hmm. I would say, like, when you first started to ask me, like, what's my hardest case, it would have been like my case. Like that was the hardest one for me personally to deal with, which we can get into in a little bit. But I understand that young people in foster care, first of all, are eligible for Medicaid cases, for Medicaid services like the one that we're talking about, like CFTSS and community-based. They're living with a lot of trauma. They're assuming the system did a good job. It's kind of hard to put it in those terms, but assuming that they did, protect the child, like that they were living in their original, family, they were living with serious abuse and neglect, and then entered the system. They're carrying so much with them, right? Because even just the separation of a child from their family, their home, doesn't matter what the outside looking in thinks about that family. That child has a deep bond and connection with their parents. And then, so there's trauma right there in the severance of that, of the experience of a CPS investigation, of being strip searched in front of your parents and looking at them and everything you've been told as a child, like don't trust strangers and things like that. Mm-hmm. And then some stranger walks in their home and the parent is powerless. Like that, even in of itself, is deeply painful. And like often when you talk to young people who've been through foster care, one of their earliest memories, you ask, like, well, what happened to them? Like, that's when it all started, right? For better or for worse, whatever we want to say about what that family's dynamic was or what the situation was, like that's this trauma. So then we send them to strangers, we send them to congregate care settings and group homes, and then they behave in ways that adults don't like. Hey, don't do that, right? But reality is, like, these young people are going through immense pain and trauma and are having a difficult time trusting the adults in their life, trusting other young people. The world has been sort of shattered underneath them. So now, say they've been in the system for years, say they never ended up having a foster home that worked, or where they were compatible, they never had permanent supports. I think those are some of the more heartbreaking cases that people will call these young people, like, hard to serve. And so much has happened to them. It's very difficult to imagine, that one more stay in an inpatient setting is gonna repair what's happened.
Right. How does it make up for everything? Yeah.
Right. I can dovetail after that too. Just exactly what you're talking about. There's enough trauma with a kid that's kind of separated from his parents or parent and put in a stranger's home. Well, we have a kid in our home right now that's been in foster care for 10 years. His whole childhood was robbed of him, if you ask me. And this past Sunday, he literally had an explosive anger attack and destroyed a whole bunch of stuff in our home. And yet we're on waiting lists for mental health evals that we asked for a year and a half ago. A year and a half. And he's still waiting. And the half-hour therapies he's getting at the provider isn't working, because that's where it happened. where he was
In his
pulled,
mind.
and he doesn't want to go there. So of course he doesn't say anything down there. And so we're at wit's end trying to hold on this. We actually are put adoption papers in for him because I need to get him out of the system. And he needs to get out so that I can get services another way, even if it's self-pay, quicker, because we can't wait.
Right. And that's a interesting thing that our audience might not realize. When you're a foster parent, even though you're taking them into your home and you get a small stipend, in all honesty, I mean, it's not really covering everything you need to do as a parent. You can't do the things you would do if they're your biological child. You can't pay for certain things. You can't go outside of the system. You have to use the system that they give you, or you're written up, or they say that you're an unfit placement and they'll pull somebody and put them in congregate care. So there's so many complications to doing the right thing. I feel like that's almost part of the issue. I know we need to supervise and have oversight of foster care. Obviously we do. These kids are already traumatized, but if we're bouncing them from place to place and 50% of them when they age out experience homelessness, we are doing a really bad job triaging this population. I mean, now the statistics are very unsettling. I can't imagine how we can say we're doing a good job when 50% experience homelessness. And then you get into the housing piece. And if you've never had a stable family structure and you've always moved around, you are absolutely at a disadvantage when it comes to how you handle paying bills and interacting with neighbors and all of those things, because you've never been anywhere long enough to have a lasting relationship and understand how those work. I feel so strongly about that population that they need much more. And if we are pulling them from their parents and we are saying that they're at that high level of a priority, then we need to treat them like they're a priority and not just say we did the first step and that's the best we can do.
Brad, I wanted to mention, Heather and I, one of the things that we like to do, and when we talk to anybody on this, is to look at solutions with some of this. And I know working with you guys at Healthy Minds, Healthy Kids, you had an ask of $195 million on the financial piece. Is that the ask still? Is there other asks that you feel we need to fix some of these things?
Is this for the budget cycle coming up, or?
Yeah.
Okay. Mm-hmm.
So, and we talked about this at the Community Speak Out, but we've been working on this. We did a rate reform proposal, or a rate reform study, and we hired some consultants for the campaign, and just tried to determine like what could we do to alleviate the wait lists, which are connected to the workforce, right? Like, and that is connected to the rates for reimbursement to these agencies. And so, there's this sort of like strange thread coming through some like members of government and things like that, politicians, like these are greedy like therapists that are like just trying to, and these nonprofit executives trying to get a pay raise for themselves. The reality is you have to, in order to actually build the capacity to alleviate the wait lists, you have to pay agencies enough to hire, train, retain those staff so that they can go out and meet the need. And that is essentially just what is not happening at all. And there's so much history here. I mean, for 17 years, there was something called the cost of living adjustment for nonprofit community mental health and human services writ large. And for most of those years, they did not increase the cost of living for those contracts and those rates. They just said savings. That's what they called it. They declared it. They're statutorily required to offer these things every budget year. They said, actually, we're going to save the tax dollar money, the taxpayer money. And the result of that is, like, just in the behavioral health space, 500 million, probably, frankly, more, but we're just conservative estimates, $500 million that just never made it into the public system.
That's similar to OPWDD. I mean, when you have that much less spending power, you're not even covering inflation. Yeah. Yep.
And it frankly could be higher because like you compound those every year, right? Like if you got adjusted for inflation one year, the next year you apply the next round of the consumer price index and so forth. So it's frankly higher than that. But yeah, we work closely with the developmental disabilities advocates and the provider associations behind the COLA. But they're just trying to make this point of the system has been slowly made to be anemic and unable to actually meet the need and roll with the increasing costs of existing as a nonprofit agency. And then the workforce has been one of the greatest casualties of that, where their wages remain stagnant. And, public mental health system, these providers can't increase their prices, right? They're sort of beholden to whatever their existing contracted rates are with the state, unlike a lot of private, which is where people find themselves going. If you're, and you probably know this, Heather, like, where do people go if they serve an MSW to serve their time, in a public mental health system? Once they have their hours and they're able to, they can go off and hang up a shingle and go into the private side, where they'll make more money, frankly, and you can't blame them for that.
But the liability piece, people have to think about when you're working with someone who's unstable, the liability for the provider is huge. So people might say, I do not know why that doctor is billing $300 for a session, blah, blah, blah. Well, all the fees of having an office and having payroll and the taxes and having your liability insurance, at the end of the day, they are making money. But with our family, our loved ones that have come in, and if they have Medicaid, they're losing money. So we can't expect providers to lose money when we're their patients. We have to be creative, I think. Maybe incentivize it in different ways. Maybe there's a tax break they can get if they have a certain percentage of Medicaid patients at their office, or student forgiveness loans if they're accepting patients. But what we really need are the people who love us and love this population to be drawn to us and be able to afford to stay with us. Like you said, they come in, they get all this great experience, they love us, and they have to move on, or they'll live in that little 1-bedroom apartment their whole life, right? When you have your doctorate, you deserve to move on and not always be struggling, but we're putting them in a situation where they can help people, but they can't maybe help the people they want to, and that's too bad.
Yeah, and there's a quality element to this too, because the more experienced mental health practitioners are moving on and serving people who maybe don't have the higher level of need, who are entering the public health system. And so it's this perverse dynamic that's unfolding. But like it or not, money would make a huge difference in investing in rates for folks working in the community side of mental health in the public health system. And so that's essentially what we're proposing. And really just, Steve said, we have this down payment. We're saying that for outpatient clinics, for home and community-based services, we'd like to see $195 million. And that will address some things like the cost of living, but also is sort of an advancement. It's trying to catch up to the decades of lost rates through inflation and things like that. And also adjusting for the bases that were wrong, just fundamentally incorrect, and never paid for the cost of care. There was a study that came out years ago that we got our hands on, done by government partners, studying child and family treatment support services. That's the home and community-based stuff I've been talking about. And in those recommendations, they said the rates needed to be 2 to 3 times higher to actually pay for the cost of delivering the service. And so $195 million is frankly not going to solve it. It maybe will make things better and alleviate it. And that's why we contracted with some consultants to all right, let's really think about what it would take, not just to make these sort of the half measures and compromises, but to really meet the unmet needs. And so first assessing what the unmet needs are in the mental health system, And then how much would it cost to meet those needs, to get every single one of those young people the care they need it, and the frequency they need it, and in the locations they need it, which is frankly, I think very often it's getting them in the community first before things get worse, getting back to that stroke throw analogy. And that number is much higher. We're still working out the exact line, but it's somewhere in the tune of $800 million is what it would take. And I know that, I mean, folks doing the math at home, that's just over $1 billion, all things added up. And that might invoke some sticker shock. But I think the cost of not addressing the unmet needs that are happening are far greater and difficult even to calculate. And we need to make those investments. The governor's not shy about investing in mental health. But that $1 billion that was put forth when she opened up in her first budget for mental health, that's a big deal. But that was one-time spending, and 890 million of that was for capital, which means paying for things like buildings and bricks and mortars and housing improvements, which are all very important, right? Like, we need those things, helping hospital beds open back up again. Making sure that supportive housing is livable, right? That these are good homes for people to live in. All good, all important. But I think the youth mental health system, and especially outpatient and home and community based, needs a down payment. And so that's how we're framing this, is $195 million as a down payment to overhaul the system and actually start to meet the needs of young people before they become much more sick adults.
I love that. So when families, if they are listening and they want to support this initiative, this campaign, is there like a name for it, a proposition, a proposal? It's not a bill, right? This isn't legislation, or it is? I just want to make sure when they walk in their office, they know what to say.
Yeah. So you would say that, we support the Campaign for Healthy Minds, Healthy Kids rate proposal of $195 million. And we support a multi-year plan to meet the unmet needs of young people by adding an additional $800 million to improve rates and make sure we scale capacity. Like something like that. I wasn't very family friendly with just that, but that's generally it. And they know us very well. We do a lot of meetings. We have letters out. We're doing speak outs. We're doing events like this and engaging with the press. Any legislator who maybe is on the mental health committee in either the Senate or the Assembly, they're going to know about us. The governor knows about us. We're really loud and we have a strong presence. So Campaign for Healthy Minds, Healthy Kids. We have a website. You can check that out and see some of the things we've been talking about. Those fact sheets, the budget asks, the materials, how to say it. That's all there.
Perfect. And we'll make sure that that's in the podcast description. So when you're listening to this, you can look it up and be able to easily access the talking points and to be informed, because I think half of the battle for families are just knowing what to even ask for. And sometimes when we're in a situation that's stressful, we shut down. And instead of shutting down and feeling overwhelmed like it can't be fixed, cling on to something that, you guys have put the research into it. You've invested into this. You know what the numbers need to be. Now we don't have to do that part. We can just say that we support it. And that support is that collective voice that we have can mean a lot. And I think that our audience does have a lot of people in the disability community that tunes in. All of our families need the mental health piece. All of us do, no matter how well we've adjusted or really embraced the differences that our family has. By the nature of what we go through is this isolating experience, and the twists and the turns and the uncertainty. Steve and I talk to people every single day that are in very, very tenuous situations where their children do not have the supports. And one of the sad things that I've found is if you have autism and you're acting out, it's because you're autistic. A lot of times is the assumption that's made, when really you could have an underlying mental health condition. We have to appreciate the fact that the behavior means something, and that it's not just annoying or cumbersome or making it more complicated, that children don't make things up in that way. Like, like when they're presenting with something, it's an innocent thing. Like that's how their body's responding. That's how they feel. So we definitely need the professionals that can break that down. But what I see is we need the collaboration. Right now, we're so siloed. Each group is just, fending for themselves, when really we could be in a million different groups if we've thought about it. But we get assigned one, and that's our bucket of funding, and we can't go outside of it. So that's another thing to bring up to legislators, that, blending funding streams and enforcing collaboratives, between the Department of Health and Mental Health and OPW. They should all be working hand in hand, because a whole person is a whole person. You can't divide us up into, here's my intellectual disability, and then here's my physical limitation, here's my mental health challenge. We're a person, and all the pieces of us need to be addressed. We're coming up on the end of the show, and I just wanted you to have a chance to tell a little bit about your story, because you mentioned it in the middle, and I just want to give you that chance to maybe explain to our audience why this is a personal journey for you or important to you in a personal way.
Yeah. Thanks for that, Heather. I think, we were talking about this issue, and like, how do we get people to relate to this on a really like human level? And one of the things that, we talked about is like, could you just imagine a younger version of yourself and what they would have needed, or how much they would have benefited, how much more easier maybe, or your life would have been had you had someone to talk to early on, if you've been able to engage with like a therapist or somebody, to help process what happened to you, to really kind of understand your emotions. Like how much different could your life have been? And I think that's kind of what we're inviting people to understand about this issue, is that the young people right now aren't that different from who you were then. And maybe you didn't get the help. What if you did? And what if you knew a little bit more about emotions, that you may hopefully you're on that healing journey now. What if that got started sooner? What could have been avoided? And I think that I know why that came up for me as like a tactic. And that's because, I grew up in one of those sort of tumultuous households where, things were unsafe, and sometimes the people felt unsafe. Not that they ever really I experienced like abuse in that sense, but the sense of like, my parents are activated and stressed, and they have trauma, right, that they went through and that their parents went through. And there's just like this intergenerational sort of thing happening. And, they don't know how to talk about or feel safe or allowed to talk about their own feelings or how to deal with that in a healthy way. And that plays out in how, how we see our own problems as a young child. And, I lived that way. And I learned all of these maladaptive behaviors, and I used substances, and like my whole family did, like to cope. And we used relationships, and we used sex, like all of it in our own, like basically every coping strategy you could imagine, that was part of the culture of the family. And in that was love too, but also pain. And I never really got help for that. I never really connected with anyone, a therapist or anything. And like things went wrong, I was, a lot of abuse and anger and sort of like that some serious domestic situations and CPS involvement briefly. I adapted all of that. Like that's how you relate with the opposite sex, like that's how you have relationships with people. You're angry, you scream, you're like, and that carried with me all into my adulthood. Right. And, got involved in police, and I got involved in almost being pushed. Did get pushed out of my school, and all the way up until my 20s. And I just think about it, like, what if I had some of these programs? I got to talk to a Heather, back when I was 14 and really mad, and no one could help me. And that's just how I felt. And that was my approach to everything. Like how many friends would have not lost, and how many opportunities maybe would have presented themselves if I got where I am now just a little bit sooner. And I think that's what we're sort of, how I relate to this issue of youth mental health, is just thinking like, we need to get young people into the mindset of healing, of understanding their emotions, not being mad about them or afraid of them. And that would go a long way. And so that's what I hope we can accomplish with the Campaign for Healthy Minds, Healthy Kids, for the younger versions of Brads and Heathers and Steves out there.
Absolutely. And I think that we can end on the idea too, for families who are struggling and not sure what to do, but they're like, I have a really good relationship with my kid and they should be comfortable talking to me. There are some things that a teenager or a young adult don't want to talk about with their parents, no matter how close you are with them. So don't take it as, an insult or that you're doing something wrong if your child cannot open up to you. Sometimes we're empowered by telling our story to someone else and just going through that process with someone else, and then your relationship with your child or your parent is so much better because you've had that time to reflect with a neutral party, somebody who's not emotionally invested in living that same reality. So I appreciate you, sharing part of your story, letting our audience know about some of the different resources that are out there right now, and also trying to explain to people why the wait list is there. It's not that the doctors don't want to help. If there's a psychiatrist, signed up and he's taking patients, or she is, it is because they want to help. It's that the system itself needs to be reworked. And I love the idea of that down payment, because sometimes we need to really push the funds in to create the momentum. And then other people might get involved. Other community entities and resources might be drawn to it and say, how can we help and what can we do? And I think that's where the best solutions are, is when people come together and decide that they're going to do things as a group rather than individually.
Yeah, and Brad, you hit it on the head. We can close up. That the key is to nip all of this in the bud now when these are kids, because the cost when they're adults to overcome their addictions and their mental health is way, way more money. And just what we see, if we can get these kids some help early when they come through our home, many times it saves the state a lot of money down the road. And they might not have to have therapy, right, and heartache. And so it's one of the reasons I'm glad you came on. It's one of the reasons glad I got involved with you guys at Healthy Minds, Healthy Kids. And I hope that people look into what you guys are doing and support it.
Thank you so much for coming on today.
Yeah, thanks for having me. I really appreciate both of you.
Thanks, Brent.
You made a new fan inviting me, Steve, because I have, in preparation, had to watch at least a couple episodes.
Perfect.
Since you guys are there.
That's how we do it. No.
Super.
Now you're part of the fan club.
Sounds good. And I want to throw a plug out to the Solutions Not Suspensions campaign, which I meant to talk about today.
Yes.
You'll just have to have us come on again. I know you're in chats with groups like the Children's Agenda. And
I was just going to say, Iman I'm meeting with him in a couple weeks. Maybe we could have you both on, because that would be great. That'd be perfect. Let's do that.
Continue the conversation by joining our Facebook group. If you're a fan of the show, please join our supporters club. Subscribe on YouTube, rate and review on your favorite listening app, but most of all, share it with your friends. Just one more click or comment can make a huge difference and help us to continue finding common ground.